Hi, this is Eric with Survival Medicine. This is episode 34, part 2 of Bioterrorism. So let me just begin by saying that this is geared towards healthcare providers. This is more for EMS folks and first responders. Um, so for those people that are just regular folks without medical training, this information is definitely not geared to you in terms of specifics of treatment. The types of things that happen in these large-scale attacks are well outside the capabilities of an individual to prepare for or mitigate. This has to be a more systems approach. So with that in mind, let's run through this. I'm going to use scenarios to talk about different entities, and so this is scenario number 1. This assumes that you're working in an emergency room and you see this 38-year-old businessman that has been complaining of some just malaise, which again just is a general feeling of being not well. Fever, headaches, rigors are strong, shaking, chills, vomiting, backache, rash. This has been going on for 4 days. Of note, he was out of the country a couple weeks ago, just returned from London. His blood pressure is a little low. His heart rate's definitely fast at 150. His respirations are fast, breathing 30 times a minute. That's quite a bit. And he's febrile at 39 degrees centigrade. He definitely has this rash that's all over, including his face, his hands, mucous membranes, which is an important finding as well. Also, on that same shift, there's a 55-year-old female with about the same time course and the same types of symptoms. This one has a little bit more predominant cough. Again, recent travel to England to visit some extended family. This person is also quite sick, blood pressure low, heart rate fast, respiration is very fast, near the point of what we would consider respiratory failure. Very febrile at 40 degrees centigrade, and she's not satting well, only 84% on room air. A normal healthy person should have about 100% room air oxygen saturations. Also has this rash, these papules throughout the entire body, and when you listen to the lungs, you hear these rhonchi, which are some very coarse breath sounds. Here's a picture what the rash potentially could look like. Not the greatest picture, a little grainy, but some of these pictures are hard to come by. And about 2 weeks from now, you taking care of these patients develop generalized malaise, fever, and a rash. So what could this be? A lot of people that are in the healthcare industry and have been doing some biopreparation will probably recognize that this rash. So the scenario is, and this scenario I made back in the mid to late 90s, so well before 9/11, but just doing some basic research. The scenario that I came up with is a well-funded gentleman who had a beef with the United States by the name of Osama bin Laden, obtained some virus samples from the Russians as the Soviet Union was falling apart, paid people very well to sneak out some of their bioweapons, and used it to inoculate several planes going into Heathrow that went out from there and spread this around the world. And this is smallpox. The organism is also known as variola. Now, the mortality that we talk about is mortality from when smallpox was still around. So this was a number of years ago, several decades ago, actually. And medical science has advanced since then. There's a lot more knowledge and treatments for critical care and supportive treatment. So this mortality may be over-exaggerated. But going back from the data that we have several decades ago, it was as high as 30%, and then 3% if you were vaccinated. The incubation period is somewhere around 2 weeks, close to 2 weeks, about 12 days. And it's airborne transmitted, and it's highly, highly contagious. During the waning days of smallpox, it was being eradicated off the planet. There was a gentleman who was in isolation in a hospital in Germany. He was at the far end of a hall. The hallway was closed. There were nurses stationed, to make sure people didn't go in. Somebody walked up to the door, knocked on the door, was about to open it, was cracked open, said, "Sorry, you can't come in. We've got an isolation patient here." That's all it took for that person to get infected with smallpox. So this is a very contagious disease. The symptoms are initially very similar to the flu. You get muscle aches and, like I said, sort of a general feeling of nastiness, fever, chills, And then you get this rash that can appear on all parts of the body, face, arms, hands, inside the mouth, on these mucous membranes, and it's these raised bumps with kind of this central indention. They can become kind of a pus-filled little vesicles. Vesicles are, imagine what a blister looks like. That's a small blister would be similar to a vesicle. How do you diagnose this? A lot of it's just going to be based off of clinical presentation. What does the rash look like? Is the clinician familiar with it? You can also do preliminary strain reaction or ELISA testing and actually get viral cultures or electron microscopy. Now, there's no treatment for this other than supportive care. If you were exposed, you could get early vaccine, which may limit your progression to disease. So they're talking about if there was ever an incident, you quickly vaccinate all people around it to try and wall this off and protect it. Isolation. If you suspect somebody to have smallpox, they will require strict airborne precautions, as well as you and all people coming in contact with this patient. If you're concerned that a family member comes down with smallpox, that person needs to be quarantined off and everybody kept well away from them with very aggressive maneuvers to limit exposure, because again, this can be very contagious. And let's assume that the mortality is half of what it used to be. Let's say it's just 15%. That's still a very considerable mortality rate with this disease process. All right, here's some countries that are known to be developing biological and chemical weapons, or at least at one point. We could probably remove Iraq off of that, but as you can see, some of these people are not groups that we would say would be friendly to the West. All right, here's scenario number 2. This is a 44-year-old gentleman, has a 2-day history of cough, fever, headaches, myalgias, and malaise. Again, flu-like symptoms, very similar to what we saw in the last case. Blood pressure in this gentleman's a little elevated, his heart rate's slightly fast. Again, breathing a little quickly, 25 breaths per minute. Also febrile, and oxygen saturation is okay. 96%. Chest x-ray, if you get a chest x-ray, shows adenopathy, which is enlarged lymph nodes in the hilum, which is the central portion of the lungs closest to the middle of your chest. These arrows are sort of pointing out what we would be looking at in this kind of mediastinal widening due to this hilar adenopathy. Same scenario. Another gentleman, slightly older, comes in, severe respiratory failure. Stridor, which is a very prominent sound as somebody's trying to breathe in, against some restriction. Altered mental status. This person's confused, not able to answer questions appropriately. Blood pressure is in the toilet. Pulse is extremely fast. Again, respiratory rate high. Respiratory failure. Oxygen saturation 78%. Same type of thing. This widened mediastinum with the hilar adenopathy, effusions, which is fluid around the lungs. Because you're concerned that this person has a severe infection, you're doing blood cultures, you're doing sputum cultures if you can get them, you're trying to check urine, you even do a lumbar puncture seeing if this is maybe meningitis that shows red blood cells and white blood cells in the spinal fluid. Perhaps this is meningitis based off of that. Same day, you get a 30-ish-year-old male. You don't really know because he can't give you any information. He collapsed outside of the hospital with respiratory failure. He had a flu-like illness according to family members, and then had this precipitous worsening, this very sudden, abrupt kind of falling off the cliff. After 20 minutes of coming into your emergency room, the patient arrests, requiring full CPR, and despite all aggressive maneuvers, the patient dies. All local hospitals start reporting abrupt, severe respiratory failure following a flu-like illness or prodrome. Local health officials are notified as information spread. It's quickly discovered that all these patients worked in the same government building. This is a potential presentation of respiratory anthrax. Now, anthrax is an organism that lives in the soil. I could go in the backyard of my house. You probably could too. And if you knew how to, you could isolate anthrax. It's again, it's not uncommon. It's a problem with livestock. Livestock can succumb to anthrax. And years in the past, when we had a little bit more agrarian society, farmers could come down with cutaneous anthrax by touching animals that were potentially infected. This gentleman is Robert Stevens. He is the first known person in the United States to die of weaponized inhalational anthrax that I'm aware of. He died in October of 2001. Again, this is shortly after the Twin Towers attack on 9/11. And then there was the anthrax letter bombs, basically, that were sent out in the United States. Robert Stevens was, I believe, the first one reported dead. In Florida, this is a picture of the health department after this became news, and you can see all these people lined up. They were wanting some type of diagnosis and treatment, even though they had no potential exposure. And this is a very key slide. I was working in an emergency department that was far away from Florida or the D.C. area and had no connection, and we had many patients coming in wanting testing and treatment for inhalational anthrax. So the public response, the chaos, the fear, the panic that ensues after an event like this can be almost more problematic or more troublesome than the actual event. And I think that's a key thing for people to think about how they handle the worried well, so to speak. All right, anthrax is the Bacillus anthracus, which is a gram-positive spore former. Now, the reason people pressure can foods is trying to kill off some of the spores that may exist in a variety of things. And this is one that can be very hardy when it forms a spore. If it's a weaponized inhalational form and you breathe it in and you're not treated within 24 hours of your symptom onset, this is uniformly fatal as far as we've got data on. This is an extremely virulent and dangerous organism. If you eat anthrax, if it's a GI exposure, again, you can have 80 to 90% mortality despite your treatment. And if you get cutaneous anthrax, by and large, that's not anywhere near as severe. If it progresses to get in the bloodstream, which is the septicemia, then 1 out of 5 people will die despite treatment. But most of the cutaneous anthrax does not progress to septicemia. So the type of anthrax that occurs naturally with farmers or people that are dealing with livestock is nowhere near as dangerous and deadly as a weaponized version or a deliberate attack that is either inhalational or ingested. The incubation period is between 1 and 6 days. It's somewhat dependent on the amount of exposed organisms or the amount of organisms you're exposed to. Again, it can be airborne. It can be a GI exposure, so it's ingested or just through the skin. And very similar to what we talked about before: fever, body aches, cough, fatigue, flu-like illness. And then symptoms can sometimes improve a little bit before you get this very sudden deterioration where you get respiratory distress, shock, and death within 1 to 1.5 days. It's easily diagnosed with just a gram stain or some ELISA testing, and as long as it's not bred to be multi-drug resistant, this thing is fairly susceptible to antibiotics. Penicillin, doxycycline, ciprofloxacin, all those work in normal type anthrax, even if it's weaponized, meaning it's in a way that stays aloft in the air and doesn't settle to the ground quickly. So it allows the inhalational particles to get deep into the lungs. So very simple antibiotics, very cheap antibiotics can be used to treat this. Now, this is not passed person to person, so if somebody's infected with respiratory anthrax, other people are not at risk of catching it from them, so no isolation is required. All right, scenario number 3. Foreign terrorists send a video to local news as well as putting it out on social media that they just released 10 grams of botulism toxin over the city using a aerosolized dispersion method. This makes quite a bit of news, and within 4 hours of the emergency department you're working in, or say you're a firefighter, paramedic, 350 people are presenting, complaining of weakness, headache, and possible blurred vision, some of the symptoms that were relayed to on the news broadcast of things to look for. Now, it doesn't matter whether this was real or not. If you swamp an emergency department, even in some of the larger cities with some high-capacity emergency departments, a sudden onslaught of worried well can really gum up the works. People can be calling 911. It can slow response for other people that need legitimate 911 responses, like car wrecks or heart attacks or strokes. Again, just the volume of panic can really make things difficult on healthcare providers. Now, it's not the organism in and of itself that causes the illness, but it's the toxin that it produces. This is the botulinum toxin. It's made by Clostridium botulinum, and the toxin is one of the most toxic substances known on the planet. In fact, 0.001 micrograms per kilogram, which is a minute amount, is considered lethal. It is dose dependent in terms of onset, how much you're exposed to. And it can be 24 hours to several days, depending on the amount that you're exposed to. Now, this is the same toxin that people inject into their eyelids to make them not have wrinkles. This is Botox, botulism toxin. You can inhale it, you can eat it, you can get it on your skin and absorb it. These are all mechanisms for getting botulism. Some of the early symptoms are bulbar palsies. Now, the bulbar regions are some central areas of your nervous system that control cranial nerves, basically. So some of the nerves involving the face and palate and oropharynx. So you may have some difficulty swallowing. You may have some blurred vision because your eyes aren't able to focus or track correctly. You may have double vision. And then that progresses to the larger muscle groups, the skeletal muscles. And what's dangerous about botulism toxin is it paralyzes this very important muscle called the diaphragm that is required to breathe. So dying of botulism is basically a suffocation death. Again, the diagnosis is clinical. You can use a ELISA technique to detect it. And there's also, under a terrorist or man-made attack, there are some very sophisticated systems that will sniff and detect botulism on some, just imagine a little suitcase, a little handheld suitcase that can detect this in the air or on a sample. Treatment is supportive. You have to put these people on ventilators and basically just keep them alive until it wears off. But if you have lots of people exposed, we don't have that many ventilators. It's not going to work. And so you'd have to basically employ people to sit there and squeeze a bag and artificially breathe for people that have this if all your ventilators are used up. No isolation is needed. This is not passed person to person, so it's not considered contagious if somebody happens to have botulism. All right, scenario number 4. This is a 15-year-old female, comes in with dry cough for a day. Her younger brother, who's 5, is also ill. This person has a low blood pressure, fast heart rate, febrile, sats are a little bit low. You hear these crackles, which are little bubbles moving through water, basically, a type sound in the lungs. Chest x-ray shows infiltrates was basically pus or some type of fluid in the lung. Shortly after, this patient develops severe shortness of breath, hemoptysis, and shock. And I have to apologize. If you ever look at a medical chart, and you see SOB on there, that's not an insult. That stands for shortness of breath in our world. We also have a 24-year-old male who is semi-conscious, neck pain, cough, muscle aches, which are myalgias again. Also has respiratory arrest. You put the breathing tube in him. Blood cultures show that he has this gram-negative organism in his blood. You're given a drug that treats gram-negative organisms, but despite that, this person dies shortly thereafter. This is the plague. Yersinia pestis is the organism. This is also the one that calls the Black Death. We still have this naturally occurring in the Four Corners area of the United States. Mortality, if you get it in the inhalational form, like anthrax, is 100%. Just like, if you don't treat it within 24 hours of symptom onset. The incubation period for the pneumonic form, again, I'm just speaking of the pneumonic form. There's also a bubonic form, but this is the pneumonic form, the long primary, is 2 to 3 days. And the natural way to get it is a flea vector, but it could be airborne if it's a deliberate or weaponized attack. That's usually the most common way that this would occur. High fevers, muscle aches, chills, headaches, bloody sputum. Ecchymosis is basically bruising on the skin that occurs without any kind of real trauma. Shock. You diagnose it by a simple gram stain, just looking at it on a slide. And again, as long as this is not bred to be multi-drug resistant, this is fairly easy to treat with simple antibiotics like streptomycin or doxycycline. Now, this is contagious person to person and does need respiratory isolation. All right, there's other organisms that can be used. Now, this is not meant to be an exhaustive list because there's oodles and oodles of things that could be considered a bioweapon. I'm just picking some of the highlights to run through them and talk about some general principles. But you can have viral encephalitides, depending on which one it is, whether it's the Venezuelan or the Eastern or the equine or the Western. You get this variation in the mortality associated with it. This is an arthropod vector, so a kind of mosquito spread, just like a West Nile virus, for an example, that people are concerned about mosquitoes. You get symptoms similar to meningitis, fever, headache, neurologic symptoms, just supportive treatment, and you want to limit mosquitoes so it doesn't get passed person to person. Now, this is the shepherd's crook looking virus. This is the famous one, Ebola. There's several organisms that fit viral hemorrhagic fevers, which, again, I think Ebola is probably the most famous one. Viral hemorrhagic fever is basically, or a virus, and the fact that it causes hemorrhage is the hemorrhagic part. This can cause a lot of bleeding from mucous membranes in other areas. In the United States, though, we do have dengue fever, which is been present in, I think, Florida and Texas. And we also have the hantavirus, again, which is kind of in the Four Corners area. And back in the Revolutionary War and some of our more remote history, yellow fever was very prominent. But that particular mosquito has been eradicated from the United States, so it's no longer present. The mortality can be anywhere between 1 in 5 and 9 out of 10, depending on which virus you happen to catch, and it can go from 1 week to 3 weeks for the incubation and onset. Some of these are airborne. It's unclear whether they are like Marburg or Ebola, if that is airborne or if it's strictly body fluids. But body fluids can definitely pass some of these. Fever, muscle aches, shock, profuse sweating, mucous membrane hemorrhage are all part of these symptoms. You diagnose it by getting a viral sample, and it's supportive treatment, although they have tried some antivirals like ribavirin on the Congo-Crimean hemorrhagic fever, but it's mostly just supportive. Some of these are very contagious, and so you want to have contact precautions with patients that potentially have these and really limit body fluid exposure. Now, this is a castor bean. We're going to talk a little bit about ricin, which is made from the castor plant. You used to could buy these seeds pretty easily, although they seem to be a lot less common as of late. Ricin is a very strong cytotoxin, so it attacks part of the cellular mechanism. It's a byproduct of creating castor oil, and castor oil is very common. It's used in a lot of different things in cosmetics and pharmaceuticals. So castor oil is produced in large volumes annually. Now, ricin in its pure form is more potent than VX nerve gas by a factor of 200. It blocks your ability for your cells to make proteins, and so you can imagine if you shut down the core mechanism of your cells, then you typically don't do well. You can get this through multiple routes of exposure in terms of breathing, eating, skin contact. There's actually a Bulgarian that was assassinated by the KGB using a umbrella that in the tip of the umbrella had a spring-loaded needle, and inside that needle was a pellet, a very small pellet with a bunch of pores drilled in it, and inside those pores were ricin. So as the KGB agent walked past this target, he actually bumped him in the shin with his umbrella and just tried to play it off as an accident, and then the target subsequently died of ricin poisoning. Death occurs within 36 to 72 hours. Supportive treatment is all that we've got. And we do have some of those sophisticated sensors and detectors that can basically sniff ricin in the air. All right, so that's kind of a summary of some of the agents. Let's talk about a little bit of things called epidemiology. So if you see a sudden increase in patients with a specific syndrome that you don't normally come in contact with, that should raise some awareness. Or if you're seeing a geographic pattern outside of where the disease normally lives. Obviously, if Ebola shows up in the United States, that's definitely outside of its normal geography and would be a big area of concern. Or if you're seeing disease that doesn't have the vector, right? So if you're in a time of year with no mosquitoes, say the dead of winter, and then you start having disease that you normally would associate with mosquito spread, that should be something that would start making you at least concerned that perhaps this is not a natural occurrence. A predominance of respiratory symptoms at presentation is another clue that this could be an attack, along with multi-drug resistant organisms or lots of sick or dead animals. Now, what do you do as a healthcare professional? Well, public health needs to be contacted. They're going to start doing all the connecting of the dots. FBI is going to be the one that investigates this as a potential crime. You need to protect yourself and your staff, because if you're sick and your staff is sick, then you're not able to treat people. You need to start gathering as much disease information as possible, and then remember chain of evidence, that if this does occur, this is a crime, and anything you can do to preserve chain of evidence can help in the final prosecution. So public health has the primary responsibility for patient care, and it's coordinating that. The FBI is going to be the investigatory arm, and FEMA is kind of the consequence management team. Now, the problems with all of these things, and I'm not blaming the feds or saying that this is poorly designed or we don't have really smart people putting this together. It's just a logistics issue, right? You need time to stage the response. It takes mobilization efforts and personnel assembly and equipment assembly to actually get it from wherever it happens to be stationed to the site that it needs to be. So this can take hours or days sometimes. So when this occurs, then the people on the ground at the time are the ones that really need to be managing the consequences. And so you kind of need to know what you're doing and how to deal with it. All right, if you want more information, the CDC's got lots of stuff on bioterrorism. Use SAMRID, which is basically the military version of the CDC, and they focus a lot on biological and chemical defense. They've got information on their website. There's the Institute for Biosecurity, and if you happen to be in Texas, the Texas Medical Association has the Bioterrorism Toolkit. All of these have very good information and resources. So if you're interested in this topic and want to learn more, this would probably be a next step to go here and start educating. All right, thanks for watching. I know that this was geared towards a little bit more on the healthcare provider side, but I think this is important for people to be aware of. Bioterrorism is, like I said, sort of a poor man's nuclear bomb in a sense. It doesn't take a lot of money and resources to do something very nasty. So everybody that can keep vigilance up, I think, is important. Thanks.